Okay. Well, Sally, would you like to do the introductions? You
Um,
found Rose.
okay. Well, I have, okay, just turned to 8 o'clock. Do we want to give it, I would say it's a minute or so early, but it's not now. It's officially on time.
Okay.
Do we expect, do we know how many registrants we had? Should we hold for a couple of minutes? So this program is co-hosted by Radical Elders and Unitarian Universalists for Just Economic Community. Um, we are aware that it is open enrollment period, that people have lots of decisions to make. And the elephant in the room is that Medicare Advantage, so-called, is often not an advantage. It can be cheaper, but it certainly doesn't cover what it purports to. And to tell us about that and discuss Medicare Advantage and disadvantage and Medicare Original in detail is Rose Roach from who works with Labor for Single Payer. She's national coordinator there, and is it Healthcare for All Michigan? Do I remember that correctly?
Minnesota.
Minnesota. Well,
You
okay.
could hear it the
Anyway,
way I said it, right? Minnesota.
better you should introduce yourself than I should screw it up. So
No.
welcome, Rose. Thank you. That's all yours.
No, don't be silly, Sally. That's just fine. Well, hi, good evening, everyone. As Sally said, I'm Rose Roach. I'm the National Coordinator for the Labor Campaign for Single Payer, and I am Chair of Healthcare for All Minnesota. I served my career. I retired in 2023 after serving 34 years in the labor movement, both in Minnesota and California, ending my career as the Executive Director of the Minnesota Nurses Association. And so, whether I was representing public school employees or nurses, the issue of healthcare, of course, is a major one for all of us, for all workers. It just became such a drag at the bargaining table that I decided to dive into policy and try to figure out what's driving costs and how could we actually have a system that centers patients and providers as opposed to profit by corporate entities. And so it was a very good fit to work for the nurses and to be working on both national single payer, Medicare for all, at the same time that we're trying to do something here in the state of Minnesota to move our state bill, the Minnesota Health Plan. So Sally asked me tonight to chat with you about Medicare Advantage, and both of those entities that I am working with happen to be very involved in the work around what's happening with Medicare Advantage. What is it? What isn't it? Is it working? Isn't it working? And what should seniors be thinking about, especially in this very difficult time of open enrollment when we are seeing our healthcare marketplace basically explode, regardless of whether you are on the ACA or whether you are getting Medicaid. It doesn't matter. What happened last July with HR1 is going to impact all of us, regardless of how we obtain our health insurance and therefore health care. So I'm going to hope that I'm sharing. Is that, Terry, you tell me, can you see my notes?
Yes,
Hmm.
that's
You
good.
can see
No,
my notes. So then I got to do the
no,
other
no,
one. All
no.
right.
You had it
So your
perfect.
presentation.
Oh, no, you saw the presentation. Is that the
Yep.
presentation?
Yep.
Okay. All right. Because I want to make sure that you don't have to be looking at my notes as I'm presenting to you. So again, good evening, everyone, and thank you so much for joining me tonight here at this meeting. I want to note two things before I jump into this presentation. First, it's not meant to shame or blame anyone. We know that many retirees and a number of unions are participating in the Medicare Advantage plans. That is understandable when we consider how costly our healthcare system is overall. But it's important to know that when it comes to these private corporate advantage plans, they are not Medicare. And they are not always, as Terry said or Sally said earlier, an advantage. Medicare Advantage is the misleading name given to the corporatized portion of Medicare, the portion in which tax dollars are funneled through private insurance companies to provide enrollees a private insurance plan. And secondly, I want to say members of both major parties have contributed to the privatization of Medicare and all public health programs for that matter, including Medicaid. That's why, regardless of political party or ideology, when it comes to healthcare, it really is in all of our best interest to work together to secure public health by protecting our public health programs. When we look at one of the greatest social safety net programs ever enacted, Medicare, we can see from these headlines that the healthcare marketplace is now entrenched in our Medicare program. I'll just read a few. How health insurers racked up billions in extra payments in Medicare Advantage. Major insurers are scamming billions from Medicare, whistleblowers say. Private equity takeover of hospitals led to rise in Medicare emergency patient deaths, says a study. United Health Group, which is right here in my backyard in Minnesota, is under criminal investigation for possible Medicare fraud. 1 million plus patients lose coverage as insurers and hospitals drop Medicare Advantage. And I'll talk about why that's happening. Medicare Advantage enrollees have access to about half of the physicians available to traditional Medicare beneficiaries. And then we have sort of the ultimate headline. It's from a while ago, 2018, but it really sums up what we're dealing with in the US health system. Goldman Sachs asks in a biotech research report, is curing patients a sustainable business model? If that doesn't say it all, I don't know what does. That's pretty darn disgusting. So the focus on our system for the last half a century or so has really been on these incremental market-driven tweaks that have quite frankly failed miserably. Yet these failed strategies continue to dominate the healthcare reform debate. These market-driven reforms are known to us as something called managed care. The thing is, they don't manage care, they manage money. It is our healthcare professionals and clinicians who manage our care. Many health economists in this country hold to the idea that excessive healthcare costs in the US are due to two things: physician greed and patients getting too much care. Neither of those two diagnoses are correct, and there isn't any evidence that says otherwise, to say nothing of how incredibly insulting that is to our healthcare providers. There is, however, mountains of evidence that demonstrate the exact opposite. Managed care used to be HMOs, you all have heard of those, health maintenance organizations, right? Privatized healthcare. These managed care schemes have increased costs, they have done little to nothing to improve quality, and they have actually exacerbated health disparities while driving extreme market consolidation. You can't use market forces to control healthcare prices because healthcare isn't a consumable good. So what is driving costs? Well, to quote the late Uwe Reinhardt, a Princeton economics professor, it's the prices, stupid. And we never get to really know what the true price is because the whole industry is shrouded in secrecy. And just to be clear, a significant part of that price includes unnecessary administrative costs. In terms of the workforce, that translates into a 4,000% increase in administrators into the system, and only about 100% increase in physicians that are entering the healthcare field in that same 40-year span that you're seeing, or 50-year span, that you're seeing on the screen. This is upside down in a big way, and it is a major cost driver in our system. And this is what I'm talking about when I say market consolidation. This is what that looks like under managed care ideology. Consolidation and merger frenzy within healthcare increases prices. 7 large corporations pretty much control all aspects of healthcare, except, of course, for actually providing the care. They do everything they can to prevent you from getting care because that's the only way they can make money. That market consolidation is also causing healthcare deserts because healthcare corporations are making decisions about where to open or close healthcare facilities based on their bottom line, not on the community's healthcare needs. Rural healthcare is particularly affected by healthcare corporatization and merger mania as we see continual closures of rural hospitals and/or reductions of services. We must get back to hospitals serving as a true community asset. That healthcare landscape has set up the environment that is now causing the privatization of our Medicare fund. I want to remind everyone that when Medicare was enacted back in 1965, the reason LBJ started with those over 65 and the disabled is because insurance companies didn't want to insure old and sick people. And it seems that over the past half a century, they've had a change of heart about that. Willie Sutton, a bank robber from the gangster era of the early 1900s, was once asked, "Why do you rob banks?" And he responded, "Because that's where the money is." Well, Medicare is where the money is. Of course, Medicare isn't perfect. It has its flaws. And I'm going to talk about how we fix those, but never forget that Medicare desegregated hospitals has far fewer barriers to care than the private plans do and operates much more efficiently and is more cost effective than privatized Advantage plans are. So we have seen many statements like this one from the Kaiser Family Foundation, which is now known as just KFF. They changed their name, amongst others, that have consistently described the failures of corporate advantage plans to save any amount of money, but in fact, making the case that they are increasing the cost of healthcare within the Medicare program itself. You can see the quote from KFF, "Medicare Advantage has never generated savings relative to original Medicare. In fact, the opposite is true." And I just happened to come across this from just this past June. This is an article that was written by a former Republican House representative out of Pennsylvania of the U.S. Congress. And you can see here that he says overpayments and risk score manipulation have become endemic. The result is that taxpayers are spending more per beneficiary in Medicare Advantage than they would in traditional Medicare, all while beneficiaries often face narrower networks, opaque denials, and delays in getting care. So here's somebody who, as I said, privatizing Medicare was a bipartisan effort. And even in these very politically divisive times, concerns about that privatization is also coming up bipartisan. So it isn't just this former rep, but recently Iowa Senator Chuck Grassley sent a pretty nasty letter to the then CEO of United Health Group. His name was Sir Andrew Whitty, calling him out on all of what looks like and is the abuses that are happening inside of the Medicare fund based on these Advantage plans. So this gives you a sense of how Medicare plans operate within the Medicare, or the Advantage plans operate within the system. So these private insurers are making the decisions on your access to care. They are the middlemen between you and your provider. That means access to care is made more difficult as insurers institute barriers to care, like things like narrow networks. So what you end up with is about 11.7 million Advantage patients are actually in networks that exclude 70% of the physicians that are in their county. So they can't even get healthcare access in the county in which they live. Prior authorizations are barriers to care. Are barriers to care and another real obstacle for people to be able to get the care they need. They are a for-profit tactic of cherry-picking healthy seniors, while actually what we call lemon dropping sicker seniors to avoid spending money on their care needs. Right? These are all business strategies. They are not healthcare strategies. High administrative costs, which includes profits, result in 35% more in funding to Advantage plans than what would be the cost in original Medicare. In fact, I'm terribly sorry, I'm losing my voice here. In fact, the American Economic Association looked at healthcare spending and utilization in public and private Medicare and found that Medicare Advantage insurer revenues are 30% higher than their healthcare spending is. The private health insurance industry now receives more than half of their entire revenue base from public dollars, much more so than they'd receive from their commercial products. I just heard from Wendell Potter that United Health Group is up to 75% of their entire revenue base is public tax dollars. So here's how they overbill to receive these overpayments that I was mentioning. They make us appear sicker than we actually are to increase their payment rate from Medicare. They advertise to and they grab onto the healthiest seniors that they can. They cherry pick us. They receive quality bonuses that have no clear value when it comes to patient care, and paying them as if they are providing lots of care based on how they have determined how sick we are. But except they set up all kinds of barriers for us to actually utilize any of the care that they say that we need. So that means in dollars that we are overpaying them between 124 and 140 billion dollars a year. And those overpayments are not being are not being used for enrollee health care. This is the business model, as I said, that allows for these overpayments that are used for stock buybacks, shareholder dividends, and exorbitant CEO compensation packages. And it is all being subsidized by us, the working class. Advantage premiums can be low, and they can offer a few additional benefits because we're subsidizing this private program to the tune of billions of dollars a year. Prior authorizations within Advantage plans are running rampant and causing delays and, in some cases, denials of care. The new proposal that you may all have heard about, the Wiser proposal, this is the idea that RFK Jr. and Dr. Oz have come up with to insert private insurance companies into our traditional Medicare for the purpose of doing prior authorization schemes that would basically put the fox in the hen house. They will, the idea is that they would be an entity that determines what we need and what we don't need based on prior authorizations. And they're going to use this artificial intelligence machines and to actually determine all of this. This AI stuff is making me nuts these days because inside of healthcare, it may have a role in some places. It doesn't have a role in this. And remember, it's literally written this way, that the more that they seek prior authorizations and returned recommended denial of care, the more money they will be paid by Medicare. It's coming directly out of our Medicare fund. You can see here the wide use of prior authorization on different types of really regular things that we need as we're getting older, in particular, durable medical equipment, Part B drugs, hospital stays, lab tests. It's becoming untenable both for our providers and for patients in this system when they encounter this kind of tactic. Within corporate Advantage plans, death rates double after some cancer surgeries. 7.3 million people are left underinsured in these Advantage plans, and up to 20 million hours per year are wasted because care providers have to fight with insurance companies to get their patients the treatment that they need. This is all interconnected in a way that harms patients. The bottom line here is that corporate Advantage plans are not only wasting money, but they deny care and undermine the idea of equitable single-tier care for all enrollees within the program. So if not Medicare Advantage, then what? So Medicare, as you know, is an 80-20 plan. That means that Part B, which is not the hospitalization, it's, the regular stuff that we do, going to the doctor and things of that nature, to regular checkup appointments. They only pay 80% and 20% comes out of our pocket. That's why if we go on original Medicare, we have to buy what's known as a supplemental or a gap plan, right? We want to work on that. We got some ideas about it, and I'll throw those out to you here in a couple of minutes. It is more expensive to do this because the gap supplemental plans, the insurance company's smart, and so they've increased the cost of those so that they will entice you instead to go towards the Medicare Advantage plans. The thing is, and we are in an open enrollment period right now, and some Advantage plans are no longer being offered. They literally have decided to close shop. Here in Minnesota, a decent Advantage plan has decided they can't operate anymore, so they're not going to stay open for Advantage plans as of December 31st. So anybody who is on an Advantage plan that closed up shop, you now have the right to look at original Medicare with a supplemental insurance plan to cover that 20%. And the supplemental insurance plan can't underwrite you. So you're saying to me, what in the world are you talking about? A bunch of this crazy, insurance speak. So right now in Medicare, if you leave a Medicare Advantage plan just because you just want an open enrollment, you want to get out of it and go to regular traditional Medicare with a gap plan, the gap insurance company can look at what your pre-existing conditions are. And they can decide to either not insure you because you have had the unfortunate, reality of either having cancer or maybe you have heart disease or, whatever. Uh, and they can just say, we're not selling you a plan because you've got all of these, like health issues. Because why would health insurance cover health issues? Or they could say, well, we'll take you, but we're not going to cover any of your cancer or your heart treatment or anything because that's just too expensive. We'll just cover the stuff that we don't know about basically. Or they may say, we'll cover it all, but your gap insurance plan will be, $900 a month and nobody can afford that, right? So at least not those of us in the working class generally. So so they get us between a rock and a hard spot. But if your Advantage plan has gone away, the Medicare supplemental plans can't underwrite you. They got to just take you. And so they can't play with any of that shenanigans. But it is important to know that you are going to pay more for sure because we're in a marketplace, not so much in a healthcare system. But if you can afford those dollars on the front end in your monthly payment, trust me, it will be worth it in the long run because you will not be risking those big possible surprise bills on the back end or all kinds of nonsense with network issues and with prior authorizations and with claims denials. I am fortunate to be on original Medicare with a gap insurance plan, and I am telling you, nobody questions nothing. I haven't had an out of pocket other than a couple of bucks for, high blood pressure medicine that I get for every 90 days. It's just, and anywhere I go in the country, something happens to me, there will be a doctor in a hospital that'll take me because original Medicare, everybody's in network pretty much for that. Very few hospitals or physicians will not treat original Medicare patients. But if you're on Medicare Advantage, you better make sure that you've got some coverage if you go out of state or if you're a snowbird or whatever, because you might not have your treatment available to you because it's considered out of network and you're going to get stuck with the whole bill. So even though it does cost more, if you can possibly afford it, like I said, we're going to pay for it one way or another, folks. Try to afford it on the front end. It will give you much, much more peace overall when it comes down to it. Now, you do have to purchase a Part D drug coverage plan. I just helped a family member find one for $20 a month because he doesn't happen to be on any like major, drugs or anything. So we were able to get a cheap plan there. And of course, you have to buy dental and vision. That's not covered under Medicare either. Some of the Medicare Advantage plans cover some of these things or all of them. But if you're doing traditional Medicare, you do have to add those as additional costs. So I get it. It's costly and we need to fix that. So I'm going to make some suggestions about how we could possibly do that. So just so you're aware, as I said, if you go with a supplemental plan, you'll also need to purchase a separate pharmacy and which is Part D to cover prescription drugs. And therefore you'll basically have three medical cards: Medicare, the supplemental plan card, and then the prescription drug plan card as well. We all know that seniors are on a fixed income, and therefore what we can afford monthly matters. And the supplemental plans are significantly more. So, and particularly it's going to be in 2026 because of all the craziness that's happening in the marketplace right now for health insurance. So if you feel you simply can't afford a supplemental plan, when you're researching Medicare Advantage plans, and I will send these slides to Sally and Terry, and they can get them out to you all if you want to be able to see my notes and see the slides up close and read them later. You're going to want to make sure you look to see whether or not all of your providers accept the plan that you're looking at. You must have both Medicare Part A and B and live in the service area for the plan. That is required. You must stay in the plan until the end of the calendar year. few exceptions on that, and those are outlined in the plan. Each year, plans can change benefits, so be aware of that, both premiums, service areas, provider networks, and they can terminate their contract with Medicare. There we have heard complaints from across the country, whereas there have been seniors who have found their physician in a plan, covered by a plan. They've taken that plan only to find out 3 months later that actually that physician isn't in the network. They call them ghost networks, and there's actually going to be some bills introduced, I think, next week in Congress, so that these insurance companies can't do that to us. They have to keep their network information and who's in those networks up to date regularly, so we always know who is in our network, and then we'll know how to pick our plans as well as our physicians. And you do not need a Medicare supplemental insurance plan, as I said, if you buy a Medicare Advantage. So you would just pay the premium for the Medicare Advantage plan. So these are difficult times, and there's no easy answer to what's happening right now. But if you can afford, as I said on the front end, you should consider it, because there are some long-term positives in doing so by choosing Original Medicare with a supplemental plan and a Part D plan. Original Medicare guarantees you the choice of getting the best care from the best doctors, unlike the for-profit corporatized Medicare Advantage plans. The Advantage plans often keep you from seeing the best doctors and hospitals, and they wrongly deny care that Original Medicare covers. When they're really sick, older Americans need easy access to care that they can get in traditional Medicare, not the delays and denials that we're seeing happening more and more often in Medicare Advantage plans. Corporate health insurers are forcing seniors into choosing Medicare Advantage plans, which are nothing more than HMOs or PPOs that they themselves run, by garnering huge taxpayer subsidies to bring down the premium costs. But those plans are a huge gamble, and in some cases, it's your life you're gambling with. There are some good or decent Advantage plans, and some folks that feel like they're working well for them. I hope that is true if you are on one and that it is working for you. I want you to have the care that you need without hassles. I'm just reporting as studies are being done about these plans as an aggregate across the country, more and more of these kinds of issues are actually coming up. So remember, Original Medicare was never meant to be privatized. Nothing about privatization has resulted in lower costs or improved quality of care for seniors and the disabled. It has caused nothing but confusion, stress, and anxiety across the board for all of us. I would highly recommend, if you want some completely unbiased advice on what do I do now during open enrollment? How can I compare plans? There's so much information that comes at us as senior citizens at this time of the year. Go to your local state's SHIP. It stands for State Health Insurance Assistance Program. Go to the SHIP program. It is free. It is run in collaboration between the federal government and your state, and they can help you look at all your various options and really be a financial advisor to some degree in helping you figure out what's the best plan for you based on what your health needs are and what you can afford. So as I said, you can just simply, I know I don't think I put the Minnesota one on here. I wanted to be careful because I knew I wasn't presenting to Minnesotans tonight, but you can just Google SHIP, and then it'll give you a list of the names of the different states. You just pick your state, and it should take you right to your state agency that handles SHIP. One immediate way to begin fixing this tilted system is by leveling the playing field between Original Medicare and these corporate Advantage plans. And we can do that by limiting our out-of-pocket expenses in both our Part A and Part B Medicare. We can make it so that Medigap would either be less important to have or at least less expensive to buy. We need to close the gap in the list of benefits. Traditional Medicare needs to add pharmacy, dental, hearing, and optical benefits. We also need to stop overpaying those Medicare Advantage insurers for money that they're not spending on our health care. we could use that money and to do the things that I said in the first two boxes, limit the out-of-pocket costs and close the gap in the benefits. And that is actually possible because you can see here as the PNHP, Physicians for a National Health Program, determined that it is anywhere from 83, well, MedPAC even, that's the medical council that advises Congress on Medicare. They actually even say that they're taking $83 billion a year from us and not spending it on healthcare. The folks over at PNHP say anywhere from 106 to 140 billion a year. Well, guess what? If we wanted to limit out of pocket to 5,000 a year, which is kind of equal with many of the Advantage plans that have out of pocket limits, which is way too high, by the way, but we're just trying to do apples to apples, that'd be 41 billion. If we wanted to add a pharmacy benefit to match the pharmacy benefit in current Advantage plans, that'd be 31 billion. If we wanted to add hearing, optical, and dental at the same level as the Medicare Advantage plans, guess what? We could take 85 billion and we could do all of that. Well, that's equal to what they're taking from us and not spending on our health care. So it is doable without raising anybody's taxes or raising new revenues. We're just using the money in the system and reallocating it to actual people's healthcare needs. So really the ultimate solution to this convoluted mess is to begin to building our public health infrastructure so as to create the conditions that are necessary to implement an improved and expanded Medicare for All system. How is any of this good for the working class or for public health? We do not need this complexity. We can and must instead move to this, a streamlined payment system that is publicly financed, privately delivered, and in doing so, workers and the working class can halt wage stagnation that is being caused by trying to fund a system that has no rhyme or reason as to how it is being financed. Enough of this kind of stuff. We need improved Medicare for all. It is time for us to be bold. It is time for fearless action and fearless leadership. It's time to lay out the vision and a plan that doesn't just keep putting more tax dollars into the bank accounts of these corporatized healthcare companies so they can continue to profit off human suffering. No, now is the time for a solution that speaks to our collective abundance, not this either or nonsense of scarcity that presents these false says, well, you want to feed kids or you want to give them health care? No, we ain't going to choose between them two. We're going to do it all because guess what? There is such a thing as collective abundance. That's what we need to be possible. Immigrant and racial justice, gender equality, including transgender equality, raising the standard of living for all workers, a green economy, affordable housing, fair taxation, and yes, health care for all is all possible. Si se puede. Let's get it done.
Thank you.
Happy to hang out and answer questions. I know lots of stuff going on here, and let me see real quick. Is there any way to stop that pilot program? Yeah, so the WISER program, Sally, good question. Thanks for asking that. Literally today, a bill dropped in I think it was the House, Pocan, Mark Pocan out of Wisconsin is the chief author of it, but it's with another one, and I can't remember his name. But yes, they dropped a bill today to basically prevent CMS from implementing that program.
Excellent. I happen to be in New Jersey, home of Dr. Oz, and naturally one of the 6 states, so yeah.
Oh, yes, right. Yeah, we don't, at least we're not a pilot project, but anyways, it's going to be a nightmare. So I know the states that are pilots are really working hard to try to push back on this. So let's just hope we can maybe get a bill passed on that and stop it from ever even happening. So Angel says, I'm a New York retiree fighting to keep Medicare, also part of the Radical Elders and Support NSP. I'm on Amtrak. Yes, I saw that earlier. Well, welcome, Angel. Lots of good work going on with retirees up there in New York. Boy, oh boy, you all had that big fight in New York City, to prevent retirees from going into the Medicare Advantage plans. And it looks like that fight is been won, which is just awesome. So good for you all there. It is a struggle, though. There's no question about that. But are you also going to get more coverage? Me too, which is why I am so worried about the prior author. I'm not sure, Sally, what you were
Just
talking about.
No, not to worry.
Okay, all right. Without a penalty, MA is one of the few states that allows change from Medicare. Yes, thanks for Massachusetts, right?
Right.
Thanks for mentioning that, Andy. There are, I believe, there's 4, maybe 5 states now, and they're all on the East Coast that actually do guaranteed issue on Medigap. And that is awesome. Good for you guys. We tried to do it here in Minnesota. We were all set for it to kick in on January 1 of 2026. And some legislator just
dear.
decided they didn't like it and put a bill forward to repeal it. And then another legislator said, well, maybe we shouldn't repeal it, but we should only guarantee issue for people switching between 65 and 70, not those over 70. And we should probably put a lifetime penalty percent on their, a penalty on their premium that they have to pay if they think they're going to switch from Medicare Advantage to traditional Medicare with gap plans. I am beside myself about this.
If Medicare Advantage advertising were honest, maybe. But the way they game, and mislead you, no way in hell.
Right? Yeah. No, that's exactly right. And we are pretty livid here. And we're, our actually sells, right, Medicare Advantage plans, but oddly enough, they were supportive of the Medigap guaranteed issue. And so we're working with them, and we might end up suing the state of Minnesota for age discrimination. How dare they say you can't get guaranteed issue when you hit 70? I don't think so. So, and it was a senator who was a doctor who actually came up with that. It just breaks my heart, and a Democrat, but so there you go. Let's see. I find medical drugs cheaper. Well, yes, there are ways to deal with that whole pharma situation. So we're kind of learning that as we go here as senior citizens, aren't we? Let's see, Chip with RFK and Chaz, it is time to go with Yeah, I know. I completely agree with you there. Medicare for all, yay, yes. Bernie Sanders, Medicare for all in the Senate, and Jayapal in the House. All right, I'm just trying to see if there are any other questions. And yes, you absolutely will get a copy of these slides. And like I say, you'll see my notes so that you can pick up on all of the jargon that I've been spewing out to you here for the last
Couldn't we have the recording? Couldn't we have the recording?
Yeah, that too. I think they said
because you have a passionate intensity and a thorough knowledge that comes right through, and I couldn't repeat that.
Oh, well, thank you.
So I want to play this for various groups.
Absolutely.
That's awesome. And I will, and I'll call, I see the hands up now. Thank you for the call out on that because I missed that. I will put my contact information in my email address in the chat here. Just give me 1 second. And if you have an interest in having me come and do presentations for other groups that you're active with about this, feel free. I can do Medicare Advantage. I can also just do like how crazy and insane this system is and why we need to be all fighting together for Medicare and improve Medicare for all. Yes, Chris, go ahead.
Well, I'm aware of the problems with Medicare Advantage, but my wife and I are on a program sponsored by the retirement system of the state health benefits plan.
Okay.
And they gave us a Medicare Advantage plan right out of the box when we retired. And we've been doing it for 10 years, and it hasn't been bad.
Good.
Yeah.
I'm glad to hear that. I would rather hear positive.
My mom's in that plan too. And it's true. That one's one of the better ones. I was scared as heck when they switched to Aetna, but so far, knock wood.
Good.
Yeah.
And I'm 74. My wife's a little older than I am. And I think, and the thing is, we don't pay anything. Matter of fact, the state gives us a check. Well, actually, we pay $82, and the state gives us a check for $92.
Okay.
I haven't figured that out, but things are weird in the United States, But if we were to switch all over, we'd have to pick up a Medigap and a pharmaceutical.
I know.
And I think you just said that their transition is not guaranteed unless Aetna takes a hike.
That's
So
right.
it doesn't sound, it sounds like I'm
Yeah.
trapped, Rose.
I mean, definitely on the whole guaranteed issue piece, you are potentially trapped if you're not in a state that already does guaranteed issue on Medigap. But that being said, like I said, almost in every state, there seems to be a plan, maybe two, that really doesn't quite put up the level of barriers that some of the other ones do. And here in Minnesota, that happened to be a company. Well, it's not even a company. It's a nonprofit run out of our University of Minnesota. It was called UCare. And they did, and a lot of our retirees in unions and stuff, that's where they were on, was UCare, and they got really good coverage. Now, believe it or not, though, they paid $180 a month still for that, and that was a Medicare Advantage plan. But they were treated almost as if that was Medicare plus a gap plan. I mean, they got basically, everybody in the state took UCare and blah, blah, blah. They really had hardly any obstacles at all. Now, UCare has said we can't afford to do this anymore, so we're dropping out of the Advantage program. So now I looked at a gap plan for my family member who was on Medicare Advantage under UCare, and he's going to be paying $240 more a month than he was paying before for the gap plan plus the Part D plus hearing and dental. Fortunately, he can afford that, and because he travels, he now doesn't have to worry at all anymore about a lot of things that he had to worry about under the Advantage plan. So I know it's hard, especially when we're on fixed incomes. There's only so much money we have available, and that's how they've gotten us over a barrel.
I also want to tell Pamela that Terry is almost certainly recording this webinar, so it will be available through the UUJEC.
Yeah, on
Awesome.
the website.
Yeah.
Should be
That's
up
fantastic.
tomorrow. We'll see how I go.
Go ahead,
Right.
Sally. You had a question?
A comment.
Sure.
My mom is a retired school secretary and has some friends with whom she used to work who gather from time. And I sit there and hear them talking about, oh, and we can get this credit card from the healthcare if they come and visit, and then we can get this money. And I'm saying, you guys, you're screwing it up for everybody else. I said, well, and I get it, it's tempting, but they're upcoding those folks, and
Yep.
yeah.
I mean, so when a lot of those Medicare Advantage plans will ask if they can have a nurse come out to your house,
Uh-huh.
right?
Yep.
And that's how they start to do this upcoding thing, because they'll come into the house and they suddenly will be like, you're a fall risk because you have a couple of sets of stairs. I mean, these are the different
You're
ways
diabetic.
in which they make you look sicker. One of the slides that I took out, because it gets a little bit overwhelming for folks, but it shows how, traditional, Medicare sets up payments for us as as individual payments based on some diagnostics, right? So if you're a diabetic, then they give you this sort of formula code that is going to say you're going to get more money for this patient because they're diabetic, right? And so they have potential of more things happening, etc. If you happen to be obese, if you happen to have heart disease, all of that kind of stuff. And then you come up with just a number at the bottom, and they take that number and they multiply it by another number to find out how much money do they think it would cost to take care of this patient for a year with all of these health issues. And under traditional Medicare, we've got a list of these issues, and it comes out to about $9,000 a year. When you look at the Advantage plan, the exact same patient, but they've added comorbidities into that and upcoded you, they get reimbursed for that same exact patient $32,000 a year.
Wow.
instead of 9, but you're instead of 9. And then again, like I said, then let's say something really does happen to you, then they try to screw around with you by saying, well, wait a minute, we don't know if you need that treatment, blah, blah, blah. So it's quite a scam. And here's the other thing. So one of the things they started doing, some of them are giving people like, sort of almost like gift cards, right? They're saying, gee, social determinants of health. So we're going to give you this gift card to be able to go buy food every month.
Yeah.
$200 or $100 of food every month. That sounds great. What we found out was that a lot of senior citizens are on like Section 8 housing or, getting help to do other things. That counts as income, and it's enough to put them over the limit and actually put them in jeopardy on their Section 8 housing help. So you got to be very careful about accepting these gifts from the industry.
We
And
need
Wendell Potter's
universal basic income for everybody, rich and
Well,
poor
then
alike.
there's that, right? I couldn't agree more, Pam. I'm on the same page with you. Wendell Potter is brilliant. He's a friend. We work together on this stuff all of the time. And yes, anything you can do and read with Wendell is good stuff and worthwhile for you to check out for sure. He's a great partner in this fight since he was inside the beast. And he's
Yes,
Yeah,
his book talks about that. It's really
he's trying to make reparations now.
he definitely
didn't realize.
He
And he's
came
doing
to
some
a,
amazing work.
PDA meeting one summer in Cleveland, and I sat down and worked with us. He didn't just come there as a celeb.
Yeah.
Great
Yes,
guy.
no, that's Wendell in a nutshell for sure. He loves to interact and brainstorm and learn from people. And if you talk to him long enough, he'll find a reason to say, I want to interview you and write an article about that. So
Where are you located?
I'm in St. Paul, Minnesota.
And where is Wendell Potter located?
Wendell is on the East Coast. I don't know if he's in DC. I mean, he was born and raised in Tennessee. He was in Pennsylvania for a while. I'm not sure if he's decided to get closer to the DC area because I know a lot of his staff are based out of DC that he has in the Center for Health and Democracy. But he's out there on the East Coast somewhere. That I know.
And he's got an excellent Substack.
Yes,
Thinking
he's got
about
an excellent
himself and his
Substack.
guests.
Excellent.
Healthcare Uncovered. You can get it for free. Sign up for it. It'll blow your mind. For sure, for sure. Well, if there are no other questions, I very much appreciate this opportunity. I hope it was helpful to just give you some food for thought. And as I say, I completely understand the finances of this. That's why we just got to we've got to do a disruptive solution because this idea that we can somehow subsidize our way to universal health care is nuts. It's just not going to happen.
Well,
it is not possible.
I
So-
think it feeds a political animal is the problem.
Yeah.
The privatizers can grease palms, and
Oh,
so
absolutely.
the politicians are going along with it, and it just screws everybody else.
Well, Terry, for a long time I've said and I'm obviously a lefty, a progressive, and I have said for a very long time that I feel like we should drop every subject, as hard as that is to hear, and do nothing but change campaign finance, overturn Citizens United, get to public financing of campaigns, because I don't know how we move anything as long as these corporations are able to buy our Congress, and buy our government. It's just unbelievably frustrating to me. And so you're right about that. But I don't know. I refuse to give up.
Well,
That's
they
We
used
all
to
I
be-
know.
pump money into the bottom. It flows up.
Mhm.
The economic inequality is
Yes.
so bad.
So
It's
bad.
worse than before the Great Depression.
Yeah. Yes.
And it means that we have no power.
Yeah. It's a
We
very
need-
difficult time.
It's like the Democrats, the only thing they do really well is to stop the progressives, the real progressives like
Yeah.
Bernie Sanders and AOC, from
Yeah.
ever getting real political power.
He's a runner,
Yeah,
Drew. Maybe we
it's-
got a break.
It's really, really, it's difficult, and it really is one of those things about, I'm convinced that as much as we have to talk about harm mitigation right now, like whether or not we need to get those subsidies extended, probably, even though the subsidies just go into the bank accounts of insurance companies, so it's not really helping the overall system, right? But there are a lot of people in this country that count on that subsidy as their only way to access healthcare. So we have to be somewhat compassionate about that, right? And so I talk about it in the way of saying we have the system we have, so we have to mitigate harm, but at the same time, we have to use that as the example to say this is why this system is unsustainable. We cannot sustain this anymore. And now let's go ahead and start to build our public health infrastructure and get us to the North Star, which is actually a single payer Medicare for all system that is going to cover everybody, no exceptions, save us money, and improve the quality of care in this country. I mean, I don't know why it doesn't work to say to any worker, what would you like another 12 grand in your pocket every year? Because that's what we're giving up every time we're transferring our wealth as workers to the corporate bosses when we sit at a bargaining table and put all the money that might be available for our wages into insurance premiums.
Right.
It makes
And we
no
can't
sense.
compete on a national scale
That's
because
exactly
our
right.
employers are weighted down with paying the health
That's right.
care,
Yep.
the inflated health care costs of our workers. And we're stuck in the jobs because
That's right.
if we need health care, because you can't move, you might lose your health care and go bankrupt.
Right. It's I mean, it's a
stupid.
weapon they use in the class warfare
Yeah.
that we're engaged in, right? I mean, there's no question about it. And I heard a patient when I was in DC recently for the PNHP National Conference, and we did a rally up on the Hill, and a patient said, no one should be poor because they're sick, and no one should be sick because they're poor. And I thought, man, that's as good an explanation of the system that we need as any I've heard in a long time.
Oh, I got to put a link into Elizabeth Warren's speech, The Coming Collapse of the Middle Class,
Oh,
which is all about, because she was a bankruptcy attorney,
Yep.
she thought bankruptcies were because people mismanaged and
funds, sure.
didn't know. And she got the data and she found out it was mostly
Medical debt.
medical and other things. And this is really great. Everybody should listen to it. And it's 1 hour. It's a speech she did in 2006, I think, before
Okay.
she was in politics. And boy, is it good.
Yeah, the idea that somebody can go bankrupt just because they, got sick is about the nuttiest thing. It doesn't even exist in any other part of the rest of the world. They don't even know what you're talking about when you say medical debt. It's like, what do you mean medical debt? That what? The pre-existing conditions. They're like, you mean medical history? I mean, right? Yeah, Sally, go ahead.
Yeah, back in 2010 with the PPACA fight, one of my biggest single payer allies was a staunch Republican who got the financial aspect completely. So,
Yep.
he carried around a poster of a waitress friend of his who had trouble with insurance.
Sure. Yeah, and that is the thing. I mean, we've got the economic argument on our side, and we've even got the moral argument, right? And the humanitarian argument on our side. But those who profit off of that suffering are not going to go easily.
And meanwhile, a couple of years ago at our annual meeting, we had a speaker, I just lost his name, from RIP, Jerry Ashton from RIP Medical Debt. They are doing
Oh,
great
yeah.
at helping people out of this mess. But we
Yes.
gotta stop more people from getting into it.
When I worked for the nurses, we actually spent $22,000 and bought $2.5 million of medical debt for patients here in Minnesota to relieve them of their debt. Because the nurses had been on strike and the public was so supportive of the nurses that the nurses wanted to give back to the community. So they just tore up $2.5 million worth of medical debt.
Yeah.
So that's how that works. Well, thank you again, all. It was wonderful meeting you, and feel free to share widely. And as I say, I did put my email address in the chat, and you're free to contact me directly if you want me to do any kind of a presentation for another group in the future. So thank you, everybody. Have a great holiday coming up in a few weeks.
Thank you. Thank you,
bet.
Rose.
Thanks
Very
for
much.
having me. Good night, everyone.
Right.
Good night.